With permission from Dr. Kundu, may I request Dr. Kunjan Kumar to come on the dais and summarize what you understood from the topics.
Good afternoon, my respected teachers and learned colleagues. Kumar has already explained everything that needed to be said. I'll just try to summarize in a couple of minutes. On a clinical basis, one thing that we need to remember is that visible hematuria is by far more common in PCC compared to RCC. And on OPD investigations, urine cytology. Now, as we all know, low-grade tumors have very poor yields, high-grade tumors have better yields. But with fluorescence-sensitive hybridization, FISH techniques, basically Eurovision is the trade name, for altered genes on chromosomes 3, 7, 17 and 9, it improves sensitivity to up to 76 to 100% in various studies. And this is a summarization of the radiological characteristics. The tumor centricity, if it is in the collecting system, it's more likely to be a pelvic TCC. If it is in the renal parenchyma, it's more likely to be either RCC. Filling defect is by far more common in TCC. The reniform shape, it will be preserved, generally speaking, in pelvic TCC unless it is very advanced, and will almost always be distorted in RCC. Cystic or necrotic change is much more common in RCC as compared to TCC. TCC has less intense but homogeneous enhancement, while RCC has much more intense but heterogeneous enhancement, and extension towards the PUJ and ureter, while may not always be seen, but if it appears, it's almost always tending towards pelvic TCC. These are a few of the images. As you can see, these are images of transitional cell carcinoma, homogeneous tumor, centrally located, not distorting the shape and invading towards the PUJ, as we can see in the lower images here. Same. And for RCC, the tumor centered in the renal parenchyma, and in the lower image we can see it is distorting the renal outline. And just to cover up the entire thing, the importance of ureteroinoscopic assessment cannot be over exaggerated. If we have an extreme diagnostic dilemma, then we can go for this. A preoperative biopsy can be used if needed, and an intraoperative frozen section.
Any question from the audience to clarify?
Suppose during operation you have detected by present section that this case I have prepared for radical nephrectomy as your RCC. What will you do?
So if there is if there is a likelihood of the diagnosis coming out at TCC, I would have already liked to counsel the patient that we may need to remove the kidney as well as the ureter. This is one thing.
Operation table. You have sent for present section. Present section has come as TCC. Then how will you proceed? What will you do?
So I will proceed with nephroureterectomy with bladder cuff excision.
Why? What are the indications of bladder cuff excision and nephroureterectomy in case of the TCC or the pelvis?
So because TCC, because transitional cell carcinoma is often a multifocal tumor with field cancerization seen.
Always you will do. What are the indications of nephroureterectomy in case of the TCC involving the kidney, pelvis of the kidney? What are the indications? Always. Anybody from the students can tell what you will do? So there are some indications when you will proceed for nephrectomy. This is not a matter of joke. You are prepared for radical nephrectomy, and suppose it has come as TCC, and you will proceed for major operation like nephroureterectomy, bladder cuff excision. It's a major operation, na? In comparison to RCC with radical nephrectomy. So you have some clues, something will guide you that whether you will do only radical nephrectomy and your ureter as much as possible, or you will proceed for major operation like very large incision or 2 incision to proceed for the bladder problem. Yes, it has been written in book when you will proceed for this and when you will do on this. Okay, any question from next to it?
What Dr. Bera was saying is that in pure renal pelvic PCCs without any urinary involvement, there is now a recent concept that you may not need to remove the intramural ureter.
Size of the tumor, gradation of the involvement, lymph nodes, many things are there which will guide.
Because removal of the intramural ureter is again a significant operation.
But definitely you have to do lymphadenectomy. You cannot avoid that.
This applies only to pure renal pelvic PCCs.
Just an observation in case of pelvic PCCs, most of the patients, even if it is a small tumor, you find a lot of desmoplastia leading operations. The radical nephrectomy is a much simpler operation compared to radical nephrectomy or radical nephrectomy in a patient of RCC. So that is reflected in CT also. Most of the cases you will find a lot of perinephric standing on the medial aspect of the pelvis, which is not seen in RCC, first thing. Second is, even if it is a small tumor in the pelvis, you might find a direct invasion of the IVC or renal vein or ipsilateral psoas. So if you find this in a non-advanced disease, you find this mostly, this is a TCC, not an RCC.
So fat standing also one big question. Fat standing.
Because as he said, there will be a local reaction to that.
I think both Dr. Kundu and you spoke on exactly the same wavelength and the same language. So I think it reiterated the thoughts much better. The question I wanted to ask both of you, can we say that RCCs are more encapsulated or they have a pseudocapsule, whereas in PCCs one does not see a capsule, one sees fringes or fingers. Can that be a way to diagnose? I would ask the two of you.
My take is you may not find a very pristine TCC. These are very early stages where you find fronds or most of the TCCs that we probably would come across would be very advanced, and they will show maybe advanced 3 type disease. They will look more fuzzy. They are renal lumps basically. So you go by homogeneity of the CT finding rather than those are, if you are very lucky to get the superficial, like in the superficial bladder cancer, some such features, that is extremely early stage. You may not get that. So you go by CT homogeneity, more important.
Yes, sir. This is basically this is what the literature says. Homogeneity is the most important landmark. Centricity of the tumor, whether it is centered in the parenchyma or the collecting system, because the renal parenchymal tumor, which RCC generally is splits in the parenchyma, so it has it may have a pseudocapsule, and while PCC expands to fill the space that is there in the collecting system. But the most important point, which we mentioned repeatedly, is centricity of the tumor. If it is centered in the parenchyma, you go with RCC. If it is collecting system, you go with PCC.
Yeah, just remember the 4 things that I told you. Don't take one out of that. Don't pluck one. Remember the 2 terms that I explained to you in detail. That's why I went through the details: attenuation, homogeneity or enhancement, shape and size, and collecting system. What is the center of the tumor? Very, very, very important. Collecting system, yes, are they involved? Not involved, like that. So think of that 4 caskets and you will usually come to a clear diagnosis.
Thank you so much. Dr. Vivaswanand Kundu sir and Dr. Kunjan.